all of you a warm welcome, and we are so happy to have you all here. The World Duchenne Organization is organizing this event since 2022 online, and before that, or 21 even. And this year, we are really happy to welcome over 600 participants from 72 countries, which is really record-breaking. Thank you so much. And this conference is made possible by the in-kind contribution of the speakers and the World Duchenne organizations. And for the French translation, we thank our member organization, Duchenne Parent Project Belgium and Land of Hope in Lebanon. And the World Duchenne Organization, for the ones who are not so familiar with us, is a global organization, an umbrella organization of national patient organizations. We are dedicated to finding a cure and viable treatments for Duchenne, but also to promote good standards of care and to inform parents and people living with the condition around the globe. And as we state in our mission and vision, there is a compelling need to ensure that wherever they are in the world, everyone diagnosed with Duchenne and Becker muscular dystrophy can benefit from a standard of care that is informed by the best practice of the best clinician from all over the world. And this is equally important, that the information available to parents and clinicians is contemporary, truthful, and is based upon the latest research. That is why this annual Duchenne Care Conference is at the core of our organization. So we are very grateful for the lineup of fantastic speakers, as well as for the input in this program by our Care Advisory Board. But last but not least, we want to thank you for your participation, because without participants, it's not a lot of value in a meeting. So here you see the map, you see around the globe how many countries are involved, which countries have really a lot of participants, which countries we can maybe next year expect people from, maybe a little bit more in Africa. And with this, I would love to introduce the first speaker, and I think Suzanne will now show the agenda. I would love to introduce the first speaker, and that is Professor Nathalie Goemans from Belgium. And we know her all as a clinician who has not only seen many, many patients, but also as somebody who has, I think you were one of the first doing clinical trials, participating in clinical trials for medication in Duchenne. And I think it's countless clinical trials you were invested. You are also serving as a member of many advisory boards, which includes being the chair of the advisory board of the accredited Duchenne Care Program. And your immense experience as a clinician seeing and treating children with Duchenne muscular dystrophy makes you the perfect speaker to start this conference with a presentation on early signs. The floor is yours.
Thank you very much for this kind introduction. I'm not sure if you can see my screen now. Can you see my screen?
Not yet.
Not yet. Okay, then I will try this. Okay. Is this better?
Definitely. If you can put it in presenter mode, this is perfect. The floor is all yours.
So yeah, thank you again for this very kind introduction, and it's my honor to be here today and to present at this Duchenne Care Conference 2024. I was not aware of the number of participants, and it's really, really tremendous good news that this is so will be seen by so many people around the world. So my contribution is indeed on the early signs in Duchenne muscular dystrophy. And as you may know, the diagnosis of Duchenne muscular dystrophy is often delayed till the age of 4 or 5, while we all know that the signs and the symptoms may occur much earlier. So the alertness for these early signs could prompt earlier diagnosis and intervention. And on the other hand, with the venue of neonatal screening programs, we may see these little ones at a much earlier stage. So being aware of possible issues may facilitate early detection of difficulties, and also, again, the implementation of early intervention strategies. So if you would ask a general practitioner or pediatrician, what are the early signs of Duchenne muscular dystrophy? You would probably receive as an answer a young boy with delayed motor development, with signs of muscle weakness, such as difficulties in struggling from getting from the floor, delayed motor milestones, and they may add as well the presence of hypertrophic calves and high CK. And yes, obviously, this is all correct, as Duchenne muscular dystrophy is primarily a muscle disease affecting the skeletal, cardiac, and respiratory muscles. However, we all know that the symptomatology of Duchenne is much more complex. And this is due to the fact that this huge dystrophin gene is not only coding for a crucial muscle membrane protein, but that this gene is coding as well for smaller isoforms that are expressed in other organs, such as the brain. And so the role of these smaller isoforms in the brain is not fully understood, and I know there will be presentations later. However, it is well established that these isoforms play an important role in the development of the brain. So it's not surprising to see that we do not only see problems in the early motor development of these young boys, but we also may see problems in other early developmental domains. What we also know is that there is a high variability in the occurrence of the developmental issues, and this can be again explained by the genetics. So where we see that the location and the site of the mutation may play a role in the occurrence of these problems. And in general, we see a higher occurrence of global developmental issues in boys carrying a mutation downstream exon 44, as this will affect the brain isoforms DP140 and DP71 that are known to be expressed in the brain. So what do we know about the early developmental domains in young boys with Duchenne between birth and the age of 6? So to answer this question, my colleague Yasmin Hoskins conducted a thorough literature review on the 5 developmental domains: motor, cognitive, language, behavior, and social emotional development in infants and young boys with Duchenne muscular dystrophy younger than the age of 6. And this review will be published soon in the European Journal of Pediatric Neurology. And so, without going into too many details, it is important to understand how these early developmental domains are assessed and which evaluation tools are available to this end. And I know there will be another presentation later on the screening of brain aspects in Duchenne. And so I just want to stress again that this is about very, very young ones. So we can identify 2 different types of assessment tools. On one hand, we have the generic tools that are suitable for a broad population. They allow the comparison of the level of development of a child with reference population. But as you may imagine, they may not capture the specific characteristics associated with specific disorders, and they might lack sensitivity to detect problems that are specific to this condition. And on the other hand, we have disease-specific tools, and those are designed to capture the specific characteristics and obviously will have a higher sensitivity and specificity in detecting the issues related to the disease. But as you may imagine, they are not always available, and especially for rare diseases and especially for subgroups of rare diseases. So what do we have as tools to assess these different domains? We see that we have a lack of Duchenne-specific tools for boys below the age of 2 years when we look at the motor skills. However, we have Duchenne-specific tools that focus on the motor skills and that can be applied, such as the time function test, the North Star, or the PUL, where we know that we have data from the age of 2.5. Unfortunately, for the other early developmental domains, we do not see Duchenne-specific tools. We do not have those Duchenne-specific tools. However, we can use the generic tools such as the Bailey scale or the Griffiths that are widely used in research and in clinical practice, where there's a lot of experience in the general population. For the Bailey, there is some literature about the Bailey. The problem is there that is reached from birth to the age of 3.5 years. While for Griffiths, for instance, we have a better range age between birth and the age of 8 years. So both are widely used, those scales are widely used in the general population. And as you can see, without going into many details, you can see how other generic assessment tools can be used to assess the other developmental domains at a young age in these boys with Duchenne muscular dystrophy. And so, well, the general conclusion of the review conducted by Jasmine Hossens is that to confirm that preschool boys with Duchenne muscular dystrophy score more poorly in different developmental domains compared to typically developing children. So most data are reported on the gross motor development. Again, maybe not surprisingly because of the nature of the disease. And in general, we can see that they achieve motor milestones at a later age compared to typically developing children, and that they walk later, with 8% walking even later than the age of 2. More than half of them had never been able to run, and 1/3 had never been able to climb stairs without support, according to a study of Grissy. And the typical early motor signs are also summarized in the recent paper from Curry, confirming on one hand the delay in motor milestones and the signs of weakness, such as difficulties with climbing stairs, getting up from the floor, but also gait abnormalities, such as stool walking, a waddling gait, and some clumsiness, such as frequent falls. To me, one of the earliest signs in the very young one is the poor head control. And when you do the attempt for the pull to sit, you will see that there is a head lag that persists even in the first years of age. The Association of Cognitive Issues with Duchenne muscular dystrophy has been reported from the 70s, past century. And when we look at preschool boy, the shift to the left on the normal distribution curve is confirmed when we use the Bailey score and the WIPSI as a screening tool. And several studies again confirm the high variability, and this is important to stress, as half of the boy will show a normal cognitive development, but also sadly up to 17% in some studies will show intellectual disability. And so, as mentioned before, there is a correlation with the location of the mutation. It's important also to note that there is no association with age, which would mean that in principle there is no mental deterioration, in contrast with the muscle problems. To me, the language development is a particularly intriguing area in Duchenne muscular dystrophy. And I know as clinician, I witnessed boys who were quite impaired in expressive language. A few of them almost mute while they were bright and perfectly normal in verbal comprehension. And the literature confirms a delayed acquisition of language milestones and lower scores on scales assessing the language development. And in general, reading abilities are more likely to be delayed as well. The behavior of boys with Duchenne muscular dystrophy has received more attention in the past decade, with more studies emerging confirming some behavioral issues in this population. And I'm sure that Jos Hendriksen will go further in detail in this aspect. And most studies report on school age and adolescence. However, according to this review, issues in cognitive development can be captured in the very young age as well. And so a higher proportion in comparison with the general population is seen on delay in adaptive behavioral skills, inattentive, impulsive, overactive, or oppositional deviant behavior have been described. The same findings as for the other developmental domains are reported on the social emotional development in the very young ones, with a slower acquisition of personal, social, and communication skills. And again, a correlation with the site of the mutation. So this slide is just to bear in mind and to repeat that there is a great variability in the presentation of the developmental issues, with indeed a higher risk in boys with Duchenne muscular dystrophy carrying a mutation downstream exon 44. The two following slides are just to highlight that data focusing on the developmental aspects below the age of 2 are still scarce. And there are some, well, this paper from Anna Connolly is quite famous, dates from 2014, and she assessed 24 Duchenne boys below the age of 2 and described the developmental aspects using the Bailey scale. But a very interesting study, in my opinion, is the study carried by Paula van Dommelen in 2020, And she did a large retrospective study in the Netherlands using data collected in centers, I call it for mother and child, where the general population is screened and assessed for developmental issues. And by doing this, she could compare the early milestones of 76 boys that were identified with Duchenne muscular dystrophy to more than 12,000 controls, and not only showing a delay in the acquisition of motor milestones, but she could also extract prediction based on the motor delay. And so not being able to walk well at 2 years predicted an increased risk in Duchenne to approximately 1 in 100 boys, while not being able to walk smoothly at 36 months predicted an increased risk of approximately 1 in 16 boys. And so this brings me to the conclusions. So not surprisingly, a subset of preschool Duchenne boys score more poorly in different developmental domains with a variability that can be explained by the type and the site of the mutation in the dystrophin gene. We do need more additional data for the very young ones and harmonization in the evaluation of the different domains, as by reviewing the literature, it was clear that different tools had been used, so making comparison quite different or difficult, or also pooling data quite difficult. And hopefully a better understanding of these early signs will lead to an earlier diagnosis and intervention. And so for a number of parents with small children with Duchenne, the motor problems are obviously of concern, but they often report that the behavioral issues, the cognitive disability, the learning disorders have the most impact on their daily life. And especially the behavioral issues can affect seriously their social and family life. There is often much compassion for motor problems and disability. However, the environment can be quite hard in judging behavior issues in children, pointing to education or other aspects. So parents often feel relieved from a feeling of guilt to hear that this may be part of the disease. And detection and anticipation of these developmental issues could facilitate early targeted intervention and also support of the family. So I think this was my last slide, so thank you. And if there are any questions, I'm happy to take them on. I see in the chat. Okay.
Thank you very much, Professor Goemans, for this presentation. I would like to introduce Dr. Karolina Podolska, who is the WDO board member and also an internal medicine physician specialized in Duchenne, and she will be taking care of the questions and answers today. So if you have a question for Professor Goemans, please use the Q&A, and Nathalie Karolina will use that to guide the discussion. Thank you.
Thank you, Suzanne. Good afternoon, everyone, and welcome. Professor Goemans, you did a wonderful job. Thank you for this presentation. I see that there's already one question in the Q&A, which, if you don't mind, we can read out loud. Based on data on motor development delays in patients with DMD, we should consider starting corticosteroids earlier. So this is not really a question, but a kind of call for action. But I did have a similar question to you. Do you know if there is data on really early use of corticosteroids available?
This is a very good question, and I think there we lack also data. We know that the age, there are a few reports on starting at the age of 2. I think that to me is the earliest age I've heard about starting corticosteroids. I think knowing the side effects of steroids, that's always the problem, how to balance these side effects. And I know that, I think it's tomorrow, Professor McCurry will talk about the importance of detecting Duchenne muscular dystrophy at an early stage, and he might address also this question. I think I just hope, how can I say it, knowing the side effects of steroids, I wish we would have products that have the same effects as steroids and would have less side effects, because especially, for instance, for the immunity, I'm concerned about kind of starting steroids at an age where a child is developing fully his immunity, and so this could have an impact on that aspect as well. But it's true that we see the breakdown of a muscle from an early age. So being able to stop this at an early age would obviously be very important. So I think having an early diagnosis is important for the motor signs, but it's extremely important, I think, for the support of the family on one hand, but also when you look at the developmental domains, like the preschool age, where I've not been into details, and this is more the results of the study that my colleague performed later. She found also quite how can I say, a difference between typically developing children and fine motor skills, which are, for instance, important when you start school. So you could start intervention programs much earlier and have these children much better prepared for entering school or kindergarten and school, which would be good for the child, but also for the families, I'm sure.
That was my other question. If you feel that what kind of area of care will be key in the future, because we know, I mean, in the early phases of life, because we know that newborn screening is becoming a topic. We are probably getting there. So then we'll have a lot of children very young to take care of, and we need to know what to offer them. So probably, as you said, earlier interventions will be.
And I've been talking about fine motor skills, where you could start to prepare them. But I think language, as I mentioned, language will be very important as well. And I think they're also having adapted training programs and preparing them for the language milestones will be also very important. So I think on one hand, we have all the motor problems and the specific muscle disease, but for the early sign, I think what will be important is addressing the developmental aspects of the child in a holistic way.
Thank you. There is another question from the audience, but I think it is more about corticosteroids. So it's about the upcoming topic.
I will leave it to my colleague. I would love to answer, but I will leave it to my colleagues. Otherwise, it's not fair.
Yes. So I think, Elizabeth, we can leave the floor now to you to introduce the next speaker.
Thank you very much.
Thank you. So yeah, interesting. So we see how many questions there are already about steroids, and the speaker on steroids still have to start. I would love to introduce Associate Professor Jana Haberlova. She's a pediatric neurologist and head of the Department of Pediatric Neurology and Neuromuscular Center at the University Hospital Motol in Prague, Czech Republic. They were the first center which were certified by PPMD. And patients with neuromuscular diseases are Jana's main focus for 15 years. And she participated in numerous trainings, but also stayed for 1 year, worked for 1 year at the John Walton Research Center in Newcastle. And then she established a neuromuscular center in Motol. As steroids remain in most countries the only available drug for all patients, and not only available, but also mentioned in the standards of care for all patients with Duchenne, regardless of their mutation. She will introduce different options we currently have with this treatments. So thank you so much for being here, Jana. The floor is yours, and you have a hot topic. That's clear. Thank you.
Thank you, Elizabeth, for this nice introduction. And as was said, I'm a pediatric neurologist. I'm a clinician. I just would summarize what we already know and what are still the questions. So just to begin, I have to ask if you will share my presentation or I should share my presentation.
If you would prefer to share your own, I think that's easiest. If
Okay,
you can't make it work, I have them as a backup.
Okay, nice. So can you see my slides?
Yes, this is perfect.
Yeah.
If you can put it in presenter mode, though.
Well, that would be the problem because I have two. Okay, maybe I try it again because I have two screens. So I stop sharing, and then we'll share the other screen. Okay. And now, can you see the presentation?
Yes, this is it.
And it's moving?
This is moving. Thank you so much. We look forward to your presentation.
Okay. So my topic, as was said, is quite hot, but you will see if I give you all answers to your question, because this story is still not finished. It's really ongoing discussion and new information. We all know the pathogenesis of Duchenne muscle dystrophy. So there is a damage of the muscle fiber. This damage indicates some kind of inflammation. So you have the cytokines release, and really it's a type of inflammation of the muscle that activate the regeneration and sometimes regeneration of the muscle fibers, but in the long term, of course, growing of the fibrosis and adiposis of the muscle. Historically, they were really first experience that if we use the steroids, it may help, and pathophysiologically, you really can influence this kind of inflammation that's caused by the muscle fiber damage to protect the muscle fiber damage, to keep the muscle as long moving as it possible. So this is the reason why we think that the steroids are working. And this is really well known. And here you can already see the first data that really proves that steroids improve the lifespan of Duchenne patient. And it really happened in 1980 when we start to use the steroids. But in that time, there were no clear what kind of steroids, what regime, and so on. It's not only that steroids improve the lifespan, but there are many studies, and this is one of the studies that show us clearly that prolong the age when the child is still ambulant. And you clearly see, and this it was really quite a number of patients, and you clearly see the differences if you use the steroids and not use the steroids. So there is really 2.5 year differences in the age when you lose the ability of walking. The same positive effect was seen when you look on these patients on the scoliosis prevention. This is different study, but again, it's like 54 DMD patients, 30 of them on steroids. And this is the most important factor of this study. This is a follow-up for more than 15 years. And you clearly see the differences between the patient that they use the steroids and not use the steroids. So again, the steroids are not there only for the lifespan, only for the ability of walking, but after losing the ability of walk, when they just start to sit on the wheelchair, there is a quite high risk of scoliosis. But if they are already on steroids, the scoliosis, it's not so frequent. I remember the time that here in our center, we were just so proud that we found a surgeon that was able to do the scoliosis surgery. And I just was speaking in some international conferences, but the others said, but now we don't see so many Duchenne patients with scoliosis because we use the steroids. So really the field is evolving, and the steroids are beneficial even in scoliosis prevention. The other important things after losing the ability of walking is scoliosis. This is the limit of the lifespan, it can be, and the quality of life, and then the ventilation. And again, there are many, I think really now papers that show clearly that the steroids are beneficial on the respiratory function as well. This is one big study done with the synergy data, and you can see here it's like about 400 DMD patients, and you clearly see that there is a difference if you use the steroids and not use the steroids in the vital capacity and the peak expiratory flow. So again, steroids are beneficial. But when you see this study, it does not answer the question, what type of steroids, what type of regime. You know that there are many types of regimes. Somebody uses the steroids daily, somebody every second day, somebody days on, day then off. And then some patients, they even use 10 days only per month or just through the weekends. And the reason why there are so many regimes are, of course, the side effects. And we all know that steroids are beneficial, but on the other hand, they bring quite a lot of side effects. And we have to be aware of these side effects, and we have to look after the patient preventively to see if there are the side effects. And if the side effects appear, then we may modify the dose, for example, or change the type of steroids. And this is the main reason why we still think about different regimes in steroids. And this is the side effects. So the most frequent side effects, of course, this is the Cushing features. But on the other hand, I know that's very important for parents and for the boys as well. But it is cosmetic things, and it does not cause any medical problems. Then growth retardation. It's important because, and you know it, when you use the steroids, even since early age, like was already mentioned by Nathalie, since the age of 2 years, that the status is quite short. From the mechanical point of view, the short status can be beneficial because it's not so difficult. As somebody is higher, then the walking is more difficult mechanically. But of course, from the psychological point of view, it's quite difficult when you compare to the peers that you just look so young if you are shorter. So this is a really big question. And this is one of the things that can be differentiated by the type of steroids you use. Then delayed puberty. That's for sure because it's a steroid. But what we can say here, this is something that can be manageable. You only have to check this, the hormones, and if there is the delay of puberty, you can treat it with hormones. So this is something that can be manageable, and I don't think that would be a big problem. Then immune adrenal suppression. This is a really important question. All patients that are using steroids for more than 3 months, they should be aware that in some acute situation, and there are recommendations, and I hope that all DMD patients, that when they use the steroids, they have a like the emergency card, what to do if they are in some acute situation. The acute situation means that if they have an infection or if they have some need of surgery, then the doctors have to increase the dose of steroids, because if you use the steroids every day, your body maybe just forgot to increase it because they are just used to the supplementation every day. So you have to know that in this acute situation, there is a risk that your body will not give you enough steroids. So be aware of it, and hopefully all Duchenne patients have to have this emergencies card. Hypertension, again, it's something that's manageable. Only you have to preventively check the blood pressure. And if there is a high blood pressure, then you can decrease the dose of the steroids, or you can use some drug for hypertension. Glucose intolerance. I'm a pediatric neurologist, and in our patient, we don't see this frequently. But of course, if there is a risk in the family, then maybe it's important. That can be more risky, but in general, I would say that in pediatric population, it's not so frequent to see a patient, DMD patient with glucose intolerance. And again, this is the reason why in the regular follow-up, we do the urine test to look for the glucose level. Again, if there is a problem, then we can just manage this problem. So this is not so big problem. Peptic ulcer disease. yes, this is a problematic, especially for the older patient. It's treatable, but sometimes can be the reason why we stop the steroids, because it can be difficulty manageable. Cataracts. Again, cataracts are more frequent in, like, for example, if you use deflazacort, and I will just show later. But this is something special, because if you use steroids and your boy shows the first symptom of cataracts, there is no way how to avoid the evolving of the cataracts. Even you would stop the steroids, the cataracts is already independent thing, that it never disappeared. It will always follow, and there will be a progression of the cataracts. But what can help, and that cataracts is already manageable, but of course it's operation, but it's manageable. But if it appears, there is no way how to stop it. So even you stop the steroids, you will not help. And then big issue is a bone density. We know that mostly all steroids, but it's different what type of steroids you use, they just decrease the bone density. And why we are afraid of decreased bone density? Because it can cause a bone fracture, and bone fracture, especially the vertebra fracture, is painful. So it's really a problem, and that's why we do preventively in patient. We do the DEXA scan and the X-ray, and then if there is a problem, then we start to use the biphosphonate. There are still not enough data to show clearly that the biphosphonate are beneficial, but there is this is the only thing what we can do. We can do preventively, so it means that the patient will use the vitamin D, and there won't be any diet with low calcium. That's the prevention. But in the ongoing follow-up, if it appears, then there is only the only way is to use the biphosphonates, and we still hope that, and in the bigger numbers, it shows that it can be beneficial, but there is no clear conclusion that would be fully recommended. In some centers, they use biphosphonate preventively when they start steroids, but this is again question is still not yet answered. And yeah, and myoglobin is not important. So many questions to steroids are still ongoing. And this was one of the first overview that tried to answer all these questions. It was 2016 when it was published, and you could only see that there are like the question like corticosteroids versus placebo. So we already know there is enough data to show that steroids are beneficial. I think that there is no question. But when you go to the regimes, that this study did not show clear answer. Weekend only or versus daily prednisone. They just compare many ongoing studies, and they just didn't find one conclusion. And then the last question was deflazacort, what type of steroid? Deflazacort versus prednisone. And even this question in this like overview, it was meta-analysis of all clinical trials that were already done, was not conclusive. So in the 2016, we used steroids already for more than 30 years, but we were not able to clearly answer this question and to recommend some easy recommendation for our patient. What we know from the standard of care that were published 2009 by Kate Bushby and her group, that it seems that the daily steroids are more beneficial than any other alternative regimes. And in that time, even this recommendation did not answer if the prednisone is better than deflazacort. It said in that time they said it's similar effect. Of course, when you are in the real world and you have two types of steroids, one is prednisone and the second one is deflazacort, then there are many studies ongoing trying to answer which one is better. And one of the study that show us maybe like some hints was published in 2015 in Neurology. It show us that maybe when you look on the two groups, and one groups use daily prednisone and then daily deflazacort. Daily prednisone is, I think, daily is the one of these one, and the green one is deflazacort. So that you can see that maybe like you would from this study you would say that maybe the deflazacort is little bit like more beneficial in the ambulation age when they lose the ambulation. But there are some other studies that did not prove these results. So it's still like in the meta-analysis, it's still not clear. But in this study was as well published the side effect. And again, these data were not proved in some other studies. So again, it's not so clear from my point of view. I think that the growth delay, they show that daily deflazacort cause more growth delay than the prednisone. But what I can agree is, and it's really clear data for this, that deflazacort use more frequently the cataracts, and that's for sure. And I can see from my experience that our patients that are on deflazacort has a higher risk for cataracts. But what's important sometimes is the regulatory rules, and deflazacort, that's Emflaza, is the only steroid that's registered for the treatment of Duchenne muscle dystrophy. So if we would follow only the medical recommendation, so the only steroid that's registered in that time, now we know that there is one more, and I will mention it later, 2017 was just deflazacort. So that's why some, mostly in US, the most frequent steroid was deflazacort. And still answer which one is better was not answered. So again, many studies ongoing, and this one is quite a big study because they have like more than 400 Duchenne patients. They've been follow up for more than 10 years. So really nice cohort. And what they prove that maybe that the deflazacort has a higher effect on the muscle strength. So it means that the group that use the deflazacort lose the ambulation in later stage. So there are some data that already are like more for the deflazacort to keep the patient ambulant. And I was so glad when Michaela Guglieri and her group published this paper. It was like 2 years ago, because it's quite nice study. And I think it was here how many patients, they were like quite a long follow-up, about 200 patients age 4 to 7, and they compare the different steroid regimes and different steroids. They use daily prednisone, daily deflazacort, and intermittent prednisone. And the results show us that, again, the daily use of steroids is more beneficial when we look on the muscle function and respiratory function. So daily steroids are more beneficial. But what does not answer was which of the steroids is better. In this cohort, there were no differences between the prednisone and deflazacort group. Only the adverse events were not the same, but not the effectiveness. And then this knowledge was again repeated in the new standard of care that were published 9 years after the first one, 2018. And again, here is written that daily steroids are better, but we don't know which one is better. So you can use prednisone or deflazacort. It means that it's on us and the families when we discuss it, which we will pick up. And in our center, the most important way how we discuss it is the differences in the side effects. We for sure know that the side effects are different, like the prednisone cause like more putting on weight, and the deflazacort cause more frequent cataracts, and the other side effects are quite, from my point of view, similar. Of course, there are the data that in some studies it's more beneficial for the deflazacort to keep the ambulation, but in some other studies did not prove this. So it's still, there is an unclarity. And then the situation is even more complicated because there is a new steroid in the market, and that's for sure that this new steroid has different profile of the side effects. And different profile, it means that one of the most frequent side effects is the short stature, and this steroid should not cause this short stature. And as I said in the beginning, it's really important factor for the DMD boys. So these steroids show that they keep the effectiveness on motor and ventilation, but have more beneficial profile of the side effects. And how we know it? They were two cohorts published. One is the third phase of the clinical trial, and the second one is the follow-up. And the third phase of clinical trial, it was a 6 months clinical trial. It was patient from 4 to 7, and they used the prednisone, vamorolone, and in 2 doses. And they found out that vamorolone in the 6 milligram per day, the higher dose, is equivalent in the effectiveness to prednisone, but has less side effects and mostly really the short stature. So it's maybe beneficial when we look on the profile of the side effect, but the effectiveness, it's quite similar. And this is the follow-up study. It was a smaller group of patients, but still from the effectiveness point of view, it shows that it really works similar as the other steroids, but has more beneficial profile of side effects. But what's important is that, of course, this drug is already registered in US, in Europe, but the price is now in Czech Republic, we still don't know. But if you look on the price for the Europe, it's quite high. So there for sure would be a problem with the regulators to persuade them that the better profile of the side effects is something that's valuable for this very big, very difference in the cause of this disease. So I'm so sorry that I cannot show you something more like clear and easy, but what I can conclude about steroids in DMD, that for sure, if we look on the regimes, the most effective regime is the daily regime. So that's what I recommend to our patient, to use the steroids daily. And then we already have like 3 steroids on the market, prednisone, but it's not registered for Duchenne. Deflazacort, it's registered for Duchenne. And then vamorolone is registered for Duchenne. The price is very different. Prednisone is just a cheap drug. Deflazacort is between, and vamorolone now looks that it would be the most expensive drug. And all these drugs have some side effects, that's for sure, but they can be different. And then sometimes it's very individual. So I recommend to our patient to start with, for us, the easiest one, the prednisone. And if some side effects appear, then we change to deflazacort. Until now, we don't have any patient on vamorolone, only patient that were on clinical trial because we were included in clinical trials. So we will see in the future, but in vamorolone situation, I think the most important would be the discussion about pricing and if there will be a reimbursement. So it's really not easy field, and for sure I don't have answers for all your questions, but that's what I think is really known, and we can prove it based on studies.
Thank you so much, Jana, for this presentation. We will kindly ask you if you now have time to answer a few of the Q&A questions that are in the Q&A session. And I will now give the floor to Elizabeth and to Jos.
Thank you, Dr. Haberlova. Yes, we're very happy that the next speaker is Dr. Jos Hendriksen. Many of you know him from like World Duchenne Awareness Day and other events where we have been discussing the problems families encounter with behavior. But today the subject is screening for brain comorbidities. And Dr. Jos Hendriksen is, I mean, not only one of the first and most active neuropsychologists in the field of brain comorbidities in Duchenne, but also is part of this EU-funded project BIND about brain involvement in Duchenne and Becker muscular dystrophy. And he created a screening tool to be used in Duchenne and Becker to pick up patients at risk. We will say again, he has been super kind to share, to offer to share also slides which are not yet published. So please don't make pictures, because or screenshots, if you do in the future, then we can't share things which are not yet published. So thank you so much for your cooperation, and thank you, Jos Hendriksen, for all you're doing and that you're here again today. Thank you. The floor is yours.
Thank you. Can you hear me?
Yes.
And can you see my screen?
Yes.
We did a good practice this morning. Thank you very much for inviting me. And thank you for the floor to tell a little bit about the screening of brain comorbidities in dystrophinopathies. This is work I did not on my own. We did it with 7 European centers on Duchenne and Becker muscular dystrophy. And I prepared this lecture together with Ruben Miranda from Spain and with my colleague Pien Werkamp from the Netherlands. So it is about, and the study which I'm going to talk is from the brain involvement in dystrophinopathies study, which is an acronym, which is in an acronym BIND. And it is about, it is a large-scale inter-center study in 7 European clinical and research centers from 6 different countries, which you can see here on the slide. 2 centers from the UK, 1 center from Denmark, 1 center from the Netherlands, from France, from Spain, and from Italy. And we had a collaborative working group with psychologists, and we aimed at targeting brain-related and neurocognitive comorbidities in a clinical sample. This is actually the ambition of the complete BIND study, which started in 2020 and which is to be finished in June next month. And data will be published in the next months, in the next year. And it has actually 3 parts. The first part is to identify behaviors affected in DMD and BMD on the basis of brain involvement of the dystrophin enzyme. The other issue is on a neuropsychiatric interview, which is called the DORBA interview, which is an online interview that parents can complete. Furthermore, we have collected data in more than 200 patients over all the centers on neuropsychological functioning, so on intelligence, working memory, and so on. And my talk today is about developing a short, fast, and reliable screening tools for neurocognitive and neuropsychiatric comorbidities, which is shortened, we call it the BIND screener or the BIND screener, which is aimed to screen for potential risks in the brain comorbidities. I will give you a sneak preview and some preliminary results because we are still collecting some data. And as the data may be subject to corrections, we ask you to be careful with the data that are present because there can be some change because we still are collecting some data and because some data need to be worked on more in depth. First, let's shortly tell a little bit about what are the brain-related comorbidities in Duchenne. And this is something I taught last year, and I go through it quickly now for those who didn't hear my talk last year. The clinical perspective on learning and behavioral comorbidities can be summarized as what we called the Big 10. So there are 10 areas that may be involved due to brain relation to brain involvement of the dystrophinopathy. And you can see it here in this slide, where you see the 4 areas: the cognitive area, the academic area, the emotional area, and the neuropsychiatric area. And you see there are 10 areas of functioning that may be involved. So on the cognitive domain, we know that intelligence may be involved in a percentage of the patients with Duchenne, but also working memory is currently much interest in because the idea is that working memory may be a central neurocognitive problem as well as executive function, the planning and the inhibition of behavior. So the neurocognitive aspects are the first domain. The second domain is about reading and about arithmetics. We know that automatization of reading and of arithmetics may be a problem in some of the boys, some of the patients with Duchenne. The third domain is about emotion, and there is mainly anxiety and depression as important areas that may be involved in dystrophinopathy. And the third area is about 3 neuropsychiatric problems that may be involved in dystrophinopathy: attention deficit disorder, autism, or obsessive compulsive disorder. And this looks fairly straight because there are 10 areas, but when you look at clinical reality, the clinical practice is much more complex. We know that when you look at boys, there may be overlap, there may be hidden areas of seemingly minor problems that are hidden by other problems. And what we know, and I will show you some results later with using the BIND screener, that there is overlap of problems and that isolated problems are rare and that most often there is a combination of problems, which makes it difficult to get a good working diagnosis. But we will discuss on this later because this is what clinical practice is believed to be and what makes a clinical diagnosis sometimes a difficult step to take. Now, what do parents need? Elizabeth Vroom and François Lamy had a very interesting talk, which was published in the ENMC meeting in 2019. And they explained what parents need. And that is the starting point for why we are interested in developing a screener. So parents need an early and a robust diagnosis to build proper care. And parents want professionals to speak the truth about the problems. But then professionals need to have an instrument to know what they are talking about, and they need to have awareness about screening and implementing existing knowledge. And one important issue which was discussed by Elizabeth Vroom and François Lamy was that it was important not to leave anyone behind in the screening. So patients with no obvious problems can have specific issues, and we know that from clinical practice, but also patients who have one comorbidities, for instance, mental retardation, can also have other related problems, because the mental problem may overshadow other problems, and it is important that we do not leave anyone behind. And maybe that is why screening may be a very important tool, because it is short, efficient, and may help to be the starting point of a robust and early diagnosis. And it may help to understand that the behavior is not a behavior problem, but is a brain-related problem. For instance, teachers, but also paramedics who complain that boys are not motivated, which sounds like a behavior problem, while in fact they are not able to cognitively quickly switch from one task to another task, which is what we call in psychology executive functions. So this is the fundamental idea why we thought that constructing a screener might help to clinical practice. The BIN screener, which we developed, has three aims. First, it is aimed to identify red flags, in other words, warning signals pointing to potential problems. So red flags, which is actually what a screener is about, is to indicate potential problems. And this can contribute to improved healthcare by highlighting areas requiring attention and facilitating targeted interventions. So, for instance, the Big 10, which I talked about. And also, a BIN screener may empower professionals and parents on brain-involved comorbidities, because we know that it is a very complex area, and with a screener, you can make it more tangible, more easy to understand and to get to the central point of what we are talking about. The second aim of the BIN screener is to monitor and to evaluate the prevalence and the severity of individual comorbidities. As you will see later on when I will present this screener, some issues, it is aimed to be administered several times if wanted, and it can help to follow up a patient or to follow up and see how problems evolve. So when we talk about the brain-related associated problems with dystrophinopathy. And the third aim is to assess the burden of the comorbidities, because what is important, of course, is the degree in which patients and parents and persons in the environment have problems with those comorbidities. And also the treatment gap. The unmet needs may be helped to get some light upon with using the BIN screener to see where there are needs that need to be that need more attention. What we did is we developed with the BIN experts, so the experts from the 7 centers from the European participating countries. We asked them to generate items on brain-related problems. And we also did a literature review. For instance, we looked at the questionnaire which was developed for tuberous sclerosis, where they also have a very nice instrument on assessing associated neuropsychiatric disorders. And we also looked at the existing questionnaires that have been used until now in Becker and Duchenne muscular dystrophy. For instance, the PARS, which is a questionnaire on psychosocial adjustment, or the SDIQ, which is an instrument on mental health. And there is also a learning questionnaire on the reading and the arithmetics. And these instruments have been used in Duchenne and Becker populations. So we could see whether there are reference values to compare or items to use in our study. The screener should be short and easy to administer. So our aim was to have a screener which could be completed in 5 minutes. It should be quick and short questions with simple answers, only yes and no answers. And when we asked on the measure of disturbance, we asked parents to rate the problems on a 5-point scale, but we do not use the not applicable alternative answer because we wanted parents to choose one of the issues, which is actually what a screener is about. Actually, we now have a screener which is 35 items, and maybe in the final version of the screener, there will be a few less items, at least that is what we are trying to do. And it has 18 items on behavioral functioning, which are to be rated on a 5-point scale from none to extremely. It has 11 previous diagnoses, whether the patient had a diagnosis before on a yes or no scale, and it has 6 items on the burden of diagnosis and unmet needs, also on a yes-no scale. So as you can see, it's a fairly easy to administer instrument, which has been used now. To summarize then, the BIN screener is easy to administer. It gives reliable and valid data, and it reveals an overlap of comorbidities, 35% as expected. It shows differences between the countries, which is expected, of course, and which should be analyzed further. And it can provide a useful screening tool for clinical practice and for over different countries. The work in progress is that in the coming months, we will do a further in-depth analysis on the data, that we will be correlating the screener data with the other data which we collected in the BIND, that we will determine clinical cutoff points to predict sensitivity, and that we hope at the end of this year we will develop a toolkit for professionals, and this toolkit will help professionals to use this screener in a valid and reliable manner, and it will be distributed by the World Duchenne Organization. So stay tuned, there is more to come. And and this is the link to the questionnaire, which is available on the BIND project webinar website. Thank you very much.
Thank you, Dr. Hendriksen. If you wouldn't mind answering a few questions in the Q&A session in writing. Unfortunately, we now don't have time to answer them live, but we thank you so much for your time and your presentation.
Yes, I will do.
Thank you so much. Thank you for this presentation. And I want to say to participants that this is not a place to ask random questions. The idea is the Q&A is to specific ask questions on the subject which you just have seen in the presentation. I see a lot of off-topic questions, and that we can't answer them today, and it's also not the place for this. So please focus in your question on the subject of the presentation. And then now we go from one Dutch to the other, right? That's a coincidence, but it makes me feel at home. The next speaker is Emeritus Professor Imelda de Groot, a pediatric rehabilitation specialist from the Netherlands. And she spent most of her professional career on care for children and adolescents with Duchenne. And her research included, amongst others, the effect of training arms and legs, the No Use is Disuse program in Duchenne. And she was also the organizer of the first sitting workshop for neuromuscular disorders in Denmark in 2019. So that is what her presentation will focus on, but she's also the program leader of the accredited Duchenne Care Program of the World Duchenne Organization, and she will speak about that tomorrow. So now the floor is yours to speak about seating, which is a subject which is not often presented and super relevant in the lives of families and patients with Duchenne. So thank you, the floor is yours.
Yes, thank you, Elizabeth, for the nice introduction. So I'm a retired professor, but I'm still working actively, and one of my topics has been also seating and positioning. And if you think this is not a medical topic, please stay listening, because I think good positioning and good seating prevents many medical issues. So keep on listening now. I'm not the only one who thinks that wheelchair seating is important. This is a recently published Delphi study from France, from Elise Dupuitier and her workers. And if you look at, they asked professionals and persons with Duchenne muscular dystrophy what they think would be important criteria for sitting in a wheelchair. And if you look at the professionals, the maximum score of this is 9, so 8 is quite high. The most important one is 9. The professionals who consisted of occupational therapists, rehabilitation physicians, and orthopedic surgeons said, well, pain is one of the most important ones, but also the use of a joystick, and also comfort. And if you go to the next slide, then the persons with Duchenne answered, and again you can see that they think some criteria are very important, and they give it a 9 or an 8.8. And one of the major points is also the ability to move, but also to have stability and comfort, but less pain. So it's an important topic for professionals, and it's an important topic for patients. And if we are looking at the core elements of being seated, then it should be comfort, seating without pain. It should be stability without risk, and I mean the risk of, for example, falling out of your wheelchair when you're driving on a bumpy street, or also sliding sidewards because your trunk is not stable. And there is the core element of balance, which means, in my opinion, means that you're not using your muscles to maintain your position, so there is less fatigue. And if we are looking at sitting in a wheelchair, we have 2 positions possible, the left one and the right one, and the left one is the better one than the right one. And I'll explain why. If you look at the left one, you can see that the femur, the upper leg, is in a horizontal position. And if you look at the right figure, you can see that the femur line is pointing downwards, which means that you're actually sliding out of your wheelchair. To get a horizontal position of the upper leg, there you can see that the cushion is of a V form. But also the feet are a little bit inclined, so this is a very stable position. While in the right figure, you're not in a stable position, and when you're rolling yourself and bending a little bit forward, there is a risk that you fall out of your wheelchair if you don't wear a belt. But still, it's not a very good position. If you look at the Duchenne-specific problems, I've taken a picture just from the website of an adult man with Duchenne, and you can see all the problems that are specific for Duchenne's. For example, if you look at his feet, you can see equinovarus feet that are not resting on the footrests of the wheelchair, but just hanging. You can look at his knees, which are sidewards, which we call an open book posture. And this makes it very unstable. If you are sitting, and if you try for yourself to make an open book position of your legs, you'll notice that you are sliding out of your chair, or the tendency to have sliding out of this chair. The second point, or the third point, which you can see in this man, is that his head is not in the mid of his pelvis, which means probably that he has a scoliosis. And he is resting more on his left side than on his right side. And if you look at his knees, there's probably also a pelvic tilt, because one knee is higher than the other one. If you look at his arms, they are not positioned on the armrest, and he has already all kind of cushions sidewards of him to maintain his position, to keep him stable. But this is asking a lot of his energy to maintain sitting in a wheelchair. So if we sum up all the influencing factors in the Duchenne muscular dystrophy, there is the development of the equinovarus feet, the ankle contractures, the development of the open book posture due to the addiction of the hip contractures, but there is also the asymmetric contractures around the hips, which probably leads to a pelvic tilt. And there can be scoliosis, although with corticosteroids it's less, but they are still present, and it can be a balanced scoliosis, like a C, where the head is still in the mid of the pelvis, but most of them are S curves, and those are normally not balanced. And last is the loss of arm strength also, so you're not able to support your trunk anymore in the wheelchair or correct your position in the wheelchair. So what can we do about this? Well, prevention is more preferable than correction. If you look at these equinovarus feet, you know there is no good position on the feet rest possible. And if there is no good bottom, you know from all kinds of examples, like the Tower of Pisa in Italy, that it will incline, it will bend to one side, and the discussion is, when is this tower going to fall? So you can better prevent it. And one of the easiest preventions is to wear good shoes. I mean ankle stabilization shoes, so above the ankle shoes, no low shoes, and it should be quite strong shoes. So if you try to pinch at the back of the shoe, what we call the contrafort, that should be strong. Another way to prevent the equinovarus is wearing night splint. And I know that many boys and men don't like the night splints, but if you're not wearing them during the night, just try to wear the night splints a couple of hours during the day. And it is also very important to instruct the person with Duchenne or sitting in a wheelchair. If you look at many persons in a wheelchair, they let their feet hanging next to the footrests, and or they are only using a part of the footrest. So instructions why it is important to have a stable sitting position, and that starts with the good position of the feet, is necessary. And not only the fact that the feet are on the right position on the footrests, it is also important to look at the footrests themselves, because due to collisions of the wheelchair, bumping into some objects, bumping into an elevator wall or something like that, they can incline downwards. So you need a regular checkup of the footrest themselves also. So what can we do for the legs? Well, one of the important things is to put side pads on the knee level. So you prevent the open book position, and a more stable position from the feet on upwards is possible. It's also like the persons with Duchenne in the questionnaire of the Delphi study already asked, to have an inclination possibility in the wheelchair. It helps to stabilize the sitting position, and it helps also to diminish the amount of energy you use for sitting. If you look at the trunk support, there are several options. You can make use of side pads, or you can make an adjustable back rest chair. This is a very sophisticated one. You can adjust each patch to the individual, so you can make a very individual backrest, but you can also do this with foam cushions, but it must be then made individual what the person needs. And I'll also show you a headrest, an adjustable headrest. And don't forget the head on the positioning in the wheelchair, because if you're flexing your head sidewards, your trunk will also fall in that position, so also sidewards. So be aware of the fact that there should be a headrest on the wheelchair. And that can be a very simple headrest, but it can also be an adjustable that can be placed on a wheelchair, a manual wheelchair itself also. So there are very many options. And if you look at the pictures that are shown in this slide, then you can also see that these persons are resting with their armrests on their arms on the armrest, which is very important. And if you have the opportunity to use an assisted arm device, which helps to level your arm, then you should be aware that this is also have impact on the trunk position. If you lift your arm above the armrest, then your position becomes unstable. In my country, I'm trying to get 2 arm devices so that you are still balanced with your trunk. If it's not possible, just look whether an extra side patch is necessary, just as the person with Duchenne is using his arm device. So if you're talking about pelvic obliquity, you can adjust that. It is either accepted or correct the pelvic obliquity. And just to get the idea whether you should accept or correct, whether a contracture is too stiff or it can still be corrected, you can place your hands under the bottom of a person who is sitting in front of you, and you can either push one side upwards and see what the trunk is doing. And this is when you decide whether you accept the position of a pelvic obliquity or whether you can correct it. And you have to do it with an individual cushion with different types of foams, some soft, some hard, some on one side a little bit higher than in the other on the other side, but you can do it with simply types of foam. The last remark I want to make is the fact that you have to approach it systematically. So you start with the feet, looking at the position of the legs, and then you go on with the pelvic. And these are pictures from an instrument which is used in the Netherlands, but there are several instruments in literature also from France. But you have to do it systematically. And if you can describe the position in a wheelchair systematically, then you can also conclude which should be changed, which can be corrected, or which can be accepted. And then you can make a plan how to approach this. Now, there are still several instruments available, but we try to get a general worldwide approach for the instrument of being seated. But this is still work going on. So probably in future, you will hear from other ones, other persons that are developing this instrument now, how you can approach it and how you can make your management plan based on this. So, and my last slide is thank you for your attention, and I am happy to answer your questions.
Thank you so much, Imelda, for your presentation. I think seating, as you mentioned, is incredibly important topic. And I would like to ask you, so in adult patients, especially, we can see changes, of course, usually very timid in the beginning, but then something goes fast and we see that the scoliosis is developing fast. Would you say there is a time then that the shape changes too fast to be able to improve it again? What is the really time to improve it?
Well, I do think that now being in the age of corticosteroid treatments, it changed because before the possibility of using corticosteroids, you knew that the scoliosis would be in puberty. So now we see scoliosis development also in adults. So one of the main important facts for the care in adults would be also screening on their backs, which many people think is not necessary because they stopped growing. But we do know that they can develop scoliosis. And if you screen regularly for scoliosis visually each half year and by X-ray each year, also in adults, you can have an idea about the progression of the scoliosis. You can still do some surgery. If you're too late, then you have a lot to do in the wheelchair to support the trunk and make it stable.
There's a question addressed to you specifically. If you would have any recommendation to avoid heel scars or hallux valgus for non-ambulant patients, any type of shoes that should be used?
No, I think you should use shoes from as young as possible, but not very. As long as they're ambulant, I always gave them very supple shoes so they can walk easily. But as soon as they're in the wheelchair, you can make the shoes more stiff, so they are like orthoses then, to keep the foot in a good position, to keep the ankle in a good position. So don't stop using shoes when they are become non-ambulant. That's my advice. So I haven't seen much hallux valgus in Duchenne, so it's probably familiar, but we give them shoes in the Netherlands.
There's another question here asking about falling on one side with not lateral support helping. You know, it's hurting the patient. He says, it hurts me, I don't want to wear lateral support. So what happens when this fails? What can we offer?
Well, that's what I'm trying to say with my presentation. Start looking at how the feet are positioned, start looking how the pelvis is, start looking at how the knees are, and probably if he still falls and is hurt, the side pad is hurting, then probably it will be in the pelvis. That is a pelvic obliquity or a pelvis rotation. So look at that and try to get a good cushion that stabilizes him from that position. So you need less side pads higher in the wheelchair.
Mm-hmm. There is a question from the Spanish audience asking if you would recommend a wheelchair for a child who is still walking. If, for example, your point of view is, yes, make it a bit easier when before he becomes non-ambulant.
I do think that children should use their energy for nice things, so playing, etc. So if you have to travel a longer distance, and normally you should walk, you could walk it with a healthy child, but the Duchenne boy loses a lot of energy in it. I would use also a wheelchair in ambulant children. The second thing why I advise a wheelchair use is that the persons know that there's something ongoing with the boy, and they will help. If he walks unstable, then there's a high risk of falling due to surrounding of other children or adults that pushes him. So a wheelchair is also a protective possibility for a young child. But my main topic is let the child use his energy for childish activities, so playing and sport, etc.
So it can be used preventively.
Yes, it can be used especially for the fatigue and especially for preventing falls.
Great. I have another question. In patients who are older, it sometimes happens that they are bound to their bed, not wheelchair anymore. How many hours a day would you recommend that sitting should be part of kind of the program, even if you are not anymore motivated to sit, to do anything? If it happens that you're kind of bound to your bed and you're used to it, sitting, if possible, should still be part of the program, let's say, or of the rehabilitation. Would you recommend any amount of hours that it should be done every day?
Well, there are no studies on that, so it's just from experience then that but are sitting or being seated in a wheelchair has some or another good chair adjusted to the individual has some pros, because it's socially more accepted to talk to a person than when you're lying down and being seated. It's also good for if you're seated, then it's also good for your lungs, because you have more room for your lungs to breathe. It's good for the circulation in your whole body too. But it has so many extras with being seated. It's more normal than lying down the whole day. But I can't give you an amount of hours, a number of hours that you should sit. We can look at spinal cord injury people, where we always say 4 hours a day is the minimum. But I really don't know whether you compare spinal cord injury patients with Duchenne patients. So it's just I think the most important thing is the psychological and social aspects.
Yes. It is really nice, the comments in Q&A. I hope you read them, because most of them say that it was really an excellent presentation and you did such a lovely job, especially raising awareness of this topic. So thank you so much.
Thank you.
And I think we can go ahead now with the others or with the next speaker, Elizabeth.
Yes, sure. Thank you so much. And again, it's a topic I think a lot of families could and clinicians could learn a lot about. So thank you so much for presenting this. And then our next presenter is maybe not a familiar face to you, but it is to me, to Imelda, because hi, Agnieszka, Dr. Agnieszka. Oh, sorry if I don't pronounce your name correctly, but it's Sobierajska-Rek.
You did very well.
Thank you. She's an assistant professor and physiotherapist at the Medical University of Gdansk in Poland, and an important member of the neuromuscular team in Gdansk. We had the opportunity to meet her in person during a visitation for the accredited Duchenne Center program, and we were impressed with her experience, her enthusiasm as well, and with how she applies telemedicine in her work, which she describes in the paper, establishing a rehabilitation program for Duchenne patients in COVID, during the COVID pandemic. So we are delighted that you're here, that you will share with us your experience, and especially your experience in the respiratory physiotherapist and how you applied telemedicine. So I would say the floor is yours. Thank you. Thank you for being here today.
Thank you for the invitation. And I will try to show my presentation. From our experience and from analysis of the wide studies about the respiratory system in Duchenne muscular dystrophy, we know that initial cause of the respiratory dysfunction in Duchenne is respiratory muscle weakness. What leads to the reduced lung vital capacity? And we know that decline of pulmonary function can be even 6 to 11% per year. So the secondary changes caused by respiratory muscle weakness would be the decrease of lung compliance and chest compliance. Of course, can cause also ineffective cough, what can lead to the repeated infections caused by the difficulties with the airway clearance. As we know, the consequences of respiratory muscle weakening would be for sure ineffective cough, can be also lung collapses, collapsing called atelectasis, reduction of lung and chest wall compliance, respiratory insufficiency, and also sleep apnea, what I will discuss in more detailed way a little bit later. what is important is to monitor the trajectory of respiratory function decline. We know that the most noticeable change of respiratory function will be observed after loss of ambulation. And what is important, that there is emphasized the strong correlation between upper limb weakening and respiratory function decline. What was also showed in our own studies that was published in 2022. Of course, there is also strong relationship between the scoliosis progression and the decline in the respiratory function. But also we have to remember that there is a lot of differences between patients, and some will demonstrate difficulties in respiratory function in earlier stage, sometimes even in ambulatory patients. And also we can find patients who are at late ambulatory stage and they still have quite good respiratory function. So of course we know that there will be a time when some patients will require some ventilatory support, especially non-invasive ventilatory support, but during the deterioration of that function, sometimes it will be needed for 24 hours a day. It is crucial for prolonging survival and quality of life in Duchenne to maintain respiratory health. And to do this, the integral part of the physiotherapy of Duchenne patients would be respiratory function assessment and respiratory function training. When we focus on assessment of the lung function or respiratory function, ventilatory function, we should focus on identifying the disorders in the system, but also the dynamics of the change. We have to observe how the function of the lungs and the function of the chest changes over time. Of course, we need to also assess the efficacy of cough and to consider sometimes the need of cough augmentation techniques or devices. Also, we should identify the risk of airway infections and, of course, the risk of respiratory insufficiency in later stages of the disease. But also, the respiratory function assessment is crucial in the assessment of effectiveness of treatment. We know that this is integral part of assessment of the clinical trials, of the pharmacological treatment, of the surgery, for example, with the scoliosis patients. Also, we will monitor in that way the efficacy of respiratory muscle training, but also efficacy of non-invasive ventilation. The parts of assessment, physiotherapy assessment of respiratory function would be, of course, pulmonary function tests, which is particularly forced vital capacity, peak cough flow, and also the assessment of respiratory muscle strength by maximal inspiratory pressure and maximal expiratory pressure. Of course, we have to notice the ambulatory status of the patient and take careful history to evaluate eventual sleep disordered breathing. And it is recommended to use, for example, pediatric sleep questionnaire, which is 22 items to investigate the presence of sleep apnea. There are questions about snoring, nightmares, sleeping disorders, headaches in the morning. So the symptoms of the sleep apnea in the pediatric patients. Of course, we should notice the frequency of chest infections, ability to clear secretions, also the efficacy and any swallowing disorders. Also, it is very important for the physiotherapist to assess breathing pattern. And what you can see here on the image, there is a Duchenne patient with some different breathing pattern, because here during the inhaling there is the paradoxical activity of the diaphragm. So the patient inhales and the diaphragm goes up. So that can happen also in the patients with Duchenne muscular dystrophy and has to be assessed. Also, the assessment of chest mobility is crucial for monitoring the functional changes. As it was mentioned, my team tried to induce some telerehabilitation and telemonitoring solutions for patients with Duchenne muscular dystrophy. And one of the elements of our research was to try to monitor the pulmonary function by remote way. So we used some remote device for measuring lung function. It was forced vital capacity to monitor, and the patients were asked to use that device 3 times a day, every day. And what we showed in the study is that it is possible to monitor the Duchenne patients in the pediatric and also young adults with Duchenne muscular dystrophy that way. And the compliance was high, and also the outcomes of the pulmonary function tests were comparable to those which were examined at the hospital. Another benefits from that home spirometry was also visible and reported by the patients, that the patients that were using this device regularly, they observed breathing improvement, and it was also visible in the spirometry outcomes. So after 3 months of daily using of the device for monitoring the respiratory function, because of forced breathing 3 times a day for 3 times, so it already improved a little the respiratory function. So it is also crucial to emphasize that that method can be used for regularly monitoring the respiratory function in Duchenne muscular dystrophy. Of course, not only assessment is important, but also the respiratory training, which is recommended as one of the key elements of DME patients management and physiotherapy. Here are some papers that emphasize the importance of that kind of physiotherapy. But also, unfortunately, we don't have strong evidence that there would be a significant improvement in the respiratory endurance or muscle strength. However, we know that in Duchenne muscular dystrophy, there is like the most principal rule in physiotherapy, not only in respiratory physiotherapy, but also in limbs physiotherapy, walking, sitting, and so on. It's use it or lose it. So if you will not use your respiratory system properly, you will lose that function. This is why even if we don't have strong evidence for significant improvement, constant training and constant activating the respiratory system will give us opportunity to preserve that function for a longer time. So still, it is very important to use that. We tried to, in the COVID pandemic, we tried to induce some respiratory rehabilitation for patients with Duchenne muscular dystrophy. We did it for the children population and older patients also. So we provided two videos for our patients to use as for training at home. The exercises consisted of breath stacking, glossopharyngeal breathing, positive expiratory pressure, and also the training of the proper breathing patterns. So we observed that that kind of program is feasible to do it at home, sometimes on the patient on his own, sometimes with the support of the caregiver or a parent. What can we recommend for respiratory physiotherapy? For sure, respiratory muscle training. And here are the techniques for positive expiratory pressure and positive inspiratory pressure. So we can use some device. There are some devices, as you can see here, that you can change from expiratory to inspiratory pressure. And we know that this kind of training can increase strength of expiratory muscle and improve muscle endurance, maximal inspiratory pressure, but also by positive inspiratory pressure training, you can strengthen the diaphragm and improve endurance. Also, it is emphasized that inspiratory muscle training should be recommended before spinal surgery as a prevention of pulmonary consequences secondary to anesthesia, but also it can increase the forced vital capacity and reduce the post-operative risks. Here on the screen, you can see the examples of the flutters that you can use for inspiratory muscle training. One of quite important technique is lung volume recruitment technique, which is also called breath stocking. We use it with the ambu-bag, with the one direction valve, and it helps to prevent atelectasis and has the most important influence in the patient with the later stage of the disease. However, we know that you should start to use it earlier. So it is recommended to start to get used to that technique in the time of transition, in the time when the patient loses the ability to walk independently, because patients rather don't like that technique so much. So it's crucial to start to use it before it starts to be very difficult. Also, technique that is recommended for late stage of the disease is glossopharyngeal breathing, which is autonomous lung inflation maneuver, and there are some indications that it can increase lung volume and delay the onset of daytime ventilator use even. So it is it's not so easy to start, but you need some instructions of your respiratory physiotherapist, but it is possible to learn how to use it. But also I would recommend to start earlier than it becomes difficult to do it. Also can be performed in the event of ventilator failure and during the inspiratory cough phase. And maybe then it can make it easier to evacuate the secretion. We don't forget about the additional elements that improve the breathing activity and respiratory function. For sure, it is swimming that is recommended for patients with Duchenne muscular dystrophy. We know that the immersion in the water can raise the respiratory muscle strength and endurance. So this is why it's a good option, and it should be considered as integral element of as recommended activity in the week of the patient with Duchenne muscular dystrophy. Also, we should not forget about standing. As far as it possible, it can be active, supported, or passive standing. Here are some examples of standing devices that are used by the patients from our center. We know that regular standing it has the influence on scoliosis prevention, but also we have to emphasize that standing position gives us highest respiratory compliance in comparison to sitting or lying. Also, patients will have the highest forced vital capacity in standing, and also the chest wall resistance is the lowest in standing positions, so it's easier to breathe when you stand. So it is very highly recommended to stand as often as possible for as long time as it possible for the patient and the patient's condition. Of course, there are a lot of other devices that can be used in respiratory management and physiotherapy. Of course, it is sometimes required to use cough assist device, or when there is mucus plaging, you can consider high frequency chest wall oscillation with the use of the vest, and also some positive expiratory pressure with oscillation, which can be used for the airway clearance, like different types of flutters, or the device which is called a cappella, and you see it on the left here on the screen. So I think it's all. So thank you for your attention, and I'm happy to answer your questions.
Thank you so much, Dr. Sobierajska-Rek. I think that you did a wonderful job, and I want to ask about the telemedicine project that you published on, and want to ask if you still use the devices after you finished the project.
Yes, they are still in use. Of course, we have some patients that use it already for 2 years, and they regularly come to the clinic only to change filters. So they use it as the regular way of respiratory function monitoring, but also as exercise of the respiratory system. But of course, there is a problem of the compliance, that there are some patients that they are not so regular in training, and if they don't have like professional physiotherapists to check if they are doing it or not, they will not do it on their own. So
okay, thank you so much for sharing this experience, and now I give the floor to Elizabeth again.
Thank you so much. Yes, thank you for your talk. And the next speakers are not online themselves at this moment. As many of us know, that there are two people who are very famous, let's say, in nutrition in Duchenne. One is Dr. Zoe Davidson, and the other is Natassja Billich. They are both from Australia. And we have invited them to speak about the delivering of nutrition care via an online program. And I think many of you might know them from earlier meetings. They are absolutely willing to answer questions afterwards, but it's middle of the night where they live. So we thought as young mothers, they better stay in bed, and they've pre-recorded their presentation. So thank you for starting the presentation, Suzanne.
Hi, everyone, and thank you to Elizabeth and the organising team for the opportunity to be here today. I'm sorry we're not here in person. It's going to be middle of the night Australia time, and we're also going to be in the middle of our Australasian Neuromuscular Network Congress. So it was great to be able to record our session today. I would first like to acknowledge the traditional owners of the lands from which we're presenting on today, and I pay my respects to the elders past, present and emerging. My name is Zoe Davidson, and I'm an advanced accredited practicing dietitian, and I'm also a researcher, and I've been looking at nutrition in Duchenne over the last 10 to 15 years. And I'm very lucky to be joined today by my colleague Natassja Billich, and I'll let Natassja introduce herself.
Thanks so much, Zoe. So my name's Natassja Billich. I'm also an accredited practicing dietitian here in Australia. I'm a researcher at the Murdoch Children's Research Institute, and also working privately as a dietitian.
So today we are going to talk a little bit about delivering nutrition care via an online program. And it's a body of work that Tash has been leading, and we've been working on here in Australia since maybe 2018, 2019. So it's great to share some of the results from this work today. Now, the program we're going to talk to focuses on weight management in Duchenne, and I'm really talking to a very lot of knowledgeable people in this area that we do struggle with weight in Duchenne. And this is just a figure from some data that Tash collected in her PhD, looking at the range of BMI measures in boys with Duchenne. And what we see from age 5 to 7 is a very strong upward trend in BMI. And it's this kind of weight trajectory that we really need to slow and bring back to the curve. We also know that increased BMI in Duchenne has some clinical consequences. So increased BMI can lead to potentially fractures at a younger age, or increased sleep disordered breathing at younger age, and the need to use things like CPAP earlier on. So it is something that we really need to tackle. So what we set out to do in this research was actually to design a nutrition program, and we did this in 2 key parts. So firstly, a survey, which I'll talk about today, that really engaged parents in Australia to understand, some of their thoughts and understandings about nutrition in Duchenne and what they would want in a nutrition program. This led to the design of a program, and then we piloted that here in Australia. And Natassja will give you some information on that as well. So just to talk a little bit about the survey today, it had 2 main aims. So firstly, in part 1, what we looked at was talking to parents about barriers and enablers to good nutrition and managing weight. So what was good and what was hard about managing weight. We also wanted to understand more about attitudes and beliefs about nutrition and weight in Duchenne. The second side of the part of the survey looked at asking parents what they would actually want in a nutrition program to help manage weight. And that gave us some really important information that led into the program development. And I'll talk about that in a moment. So this was an online survey that was conducted across the east coast of Australia, and we invited parents or caregivers with a child of Duchenne to participate in this survey. So just to go through some of the results briefly, and then we'll move on to hear about the program. So in terms of who completed this survey, we had 53 families, which encompassed 59 boys with Duchenne. And over half of these were above a healthy weight, which is what we'd expect based on the data that we've seen here in Australia. Interestingly, about 40% of children in this cohort, whether it was also their parents reporting it or their sons, talked about an intention to lose weight. And over about half said that managing weight was not easy, and we know this. So this was really confirming what we expected. Another really interesting point in the survey was we saw really high, about 2/3 of the survey reporting an avoidance of food due to certain textures, smells, or taste. So some form of restricted eating was evident in about 60% of the cohort. Positively in the survey, we did see some aspects that we really think can be enablers of good nutrition care. And what came through really strongly was that nutrition is a high priority for a lot of families here in Australia, and they did perceive weight management to be an important part of care. They did have some good insight into the consequences of weight gain. And generally, most families in our survey ate together as a family, which is actually a really positive mealtime environment for nutrition. Some of the barriers that we started to collect in terms of nutrition throughout the survey related to that really kind of restricted eating that I mentioned just before. So some of those fussy eating and sensory issue patterns can be really challenging when trying to change nutrition and intake. Managing appetite in the context of steroids was very strongly reported, and how the best ways to do that was unclear. We also noted amongst the families a really strong kind of sentiment about a lack of nutrition information within their clinics that's really specific to Duchenne. So families were really wanting specific nutrition advice for their son with Duchenne. Interestingly, we did note that there was also some nutrition gaps within the respondents. So that was useful for us to understand when designing a program, because it was clear that there was some areas that we could educate on in a nutrition program. The last ones are also, not surprising. So families reported they were time poor, and understandably, in the context of managing Duchenne, when you've got frequent clinic appointments, stretching, a range of normal household tasks on top, actually finding ways to sometimes change nutrition can be actually very challenging. Meal times were environment. Perhaps the one thing we noted was that there was a lot of screens used, and this could be something that we could work with. And also, finally, saying no was also a kind of sentiment in the survey. So saying no to treats or extra foods was challenging for parents. So the second part of the survey really talked to parents about what they would want in a nutrition program. And this helped to inform what we then went on to design. So in terms of program structure, we asked families about how they would like it delivered, how frequently they would like to have appointments, and how they'd like to be supported. And what they told us was that they really wanted that individualized advice instead of kind of maybe more generic information. They wanted it to be face-to-face, and perhaps half were happy with a phone or video call. 6 weeks in duration for a program was clearly indicated, with very similar kind of preferences around the contact. So about a third wanted weekly, a quarter fortnightly contact, and about the same for monthly visits. And finally, lots of families really wanted that support either via email or online from the dietitian throughout the program. We also talked to families about what topics they wanted covered in kind of a nutrition or a weight management program. And this gives you an indication of, I guess, the most popular topics, ranging from, managing screen time, mindfulness, quite a need around nutrition supplements and self-esteem, and then things like managing appetite and healthy meals and snacks. So all of this information was used in developing a nutrition program.
So the SNOPE design, it was focused on the whole of lifestyle approach. So it was looking at a healthy lifestyle, nutrition, and weight management. It was delivered by telehealth, and this was a combination of video calls and phone. And as you might have remembered in an earlier slide, most families in the survey suggested face-to-face was the mode of delivery that they would like. This pilot program was actually delivered during COVID through the pandemic. So we actually had to convert everything to telehealth and phone visits. And so this is the way we went with this program. It was delivered by just one person, by me, by a dietitian, and we decided on the weekly visits over 6 weeks. We were really flexible in the time of day and which day that the visits were held on. We had the luxury of that flexibility, and so we really offered a real choice to families about when they would like to see the dietitian. We delivered set topics, and we really individualized the topics depending on the family situation. So I'll go through a bit more in detail which topics were delivered. So we had 3 core topics. It was nutrition for a healthy weight, managing appetite, and then also individual advice based on some food diaries that we collected before the program started. And as I mentioned, while these were sort of general topics that were given, we really tailored these topics to each particular family. Families could then choose 2 extra topics, so healthy lunchboxes, meal preparation, mindful eating, activities and interests, and nutrition supplements. And again, tailored each of those depending on the family's needs. We, for our primary outcomes, we looked at feasibility and acceptability. And in our secondary outcomes, we looked at weight or waist circumference to have an outcome measure that could be conducted for non-ambulatory boys, physical function, which were time function tests conducted over telehealth with a physiotherapist. Quality of life, we used the PEDS-QL DMD module. Dietary intake was measured with food diaries, and fatigue, and this is self-reported fatigue, so change pre and post program. To give you a bit of a detailed overview of what the program looked like and some examples, I'll go through a case study. So this is Tom. He was a 12-year-old boy recruited through our local neuromuscular clinic, and he attended the program with his mother over telehealth. He was non-ambulatory and used an electric wheelchair. He has been on long-term prednisolone and was on a daily multivitamin and vitamin D supplement. Tom had several comorbidities. So he had autism spectrum disorder, obsessive compulsive disorder, anxiety, obstructive sleep apnea, and used a CPAP machine. So you can get a bit of a sense of how complex, Tom's situation was, lots of medical comorbidities, and how challenging weight management may be for him and his family, considering his DMD and these other comorbidities as well. So at the first visit, we set some goals around sugary drink reduction. We then had a catch up at the first phone review, which was about 10 to 15 minutes. And Tom was happy just continuing on reducing sugary drinks. And so we didn't set any new goals at that stage. We then had our second longer telehealth visit. And Tom thought he was willing to try and increase his physiotherapy activities. And so we implemented a small goal of 5 minutes in his standing wheelchair. And this was in consultation with his usual physiotherapist through the clinic. At the next phone review, he was willing to try and increase time spent in the pool, so doing some more hydrotherapy. So we set a goal around that. We, at the next visit, set a goal around trying some vegetables. And then for the remainder of the visits, there was sort of no new goals set, but just really kind of reiterating those goals that were addressed in those initial visits. The last visit was really focused on integrating Tom back into the clinic to seeing his usual dietitian and continuing on the goals that we set and some sort of forward planning for the next few months. So this is some feedback from this particular family. So you can see that some of the really acceptable approaches of the acceptable aspects of the program were the small weekly changes. So not trying to do big drastic changes at once, but focusing on little goals at a time. The weekly check-ins were really something that this family liked. So rather than having long appointments more spread apart, they liked having those quick, sharp visits that they could address some small things at a time. And they really liked the telehealth aspect as well. So that they didn't have to go into the hospital for longer appointments. They could just have these short appointments over telehealth or the phone. So overall, what went well with the SNOW-P program? So it was a small pilot study of 8 families with only 1 withdrawal. So pretty good withdrawal rate in terms of many families completed. The attendance rate was really good as well. So only 2 families missed just one of those short phone calls, and the rest of the visits were attended by all families. Most families were really satisfied with SNOW-P, and all families would recommend it to other families who have a son with DMD. Participating was quite easy. Most people said it was really easy to participate in those kind of shorter visits and over telehealth. And as I mentioned, telehealth was, an acceptable way to receive the weight management advice. Regular weekly visits was acceptable, which is, it's surprising considering the high frequency of the visits, but, that's something that the families really liked. Although we can't measure efficacy with this pilot study just because of the small numbers, but with our weight outcomes, we saw a bit of a mix, but we saw a decline in weight Z score in 3 participants, and in the further remaining 3 participants, we saw an increase in weight Z score, which ranged from a small increase of 0.04 up to a bit of a bigger increase, 0.25. There were sort of several learnings from SNOPy that we could consider in developing this program in the future. So some of the secondary outcomes were really difficult to measure over telehealth. So waist circumference measurements were quite inaccurate. So that's something to consider in the future, that perhaps that's better conducted face-to-face. And some of the completion rates of the secondary outcomes, for example, the quality of life survey, were really low. So we may need to work on how to, get those completion rates higher in the future. Having a multidisciplinary team in the future would be really important. So not just a dietitian, but perhaps having a psychologist and a physio actually delivering some of these weight management advice and goal setting. So for that reason, we didn't address self-esteem and body image, which were identified as really important topics that families would like to know more about. It's sort of out of the scope of a dietitian to kind of look at these, but perhaps a mental health clinician would be really important person to get involved with delivering these topics. As I mentioned, it was a pilot study, so we couldn't look at efficacy, particularly around those secondary outcomes. And here are some of the suggestions that participants suggested for future iterations of the program. So having some face-to-face sessions, so perhaps a hybrid model of face-to-face and telehealth, as well as some DMD specific information on an online platform, and some more visual resources.
Thanks, Tash. So I think some conclusions around telehealth and nutrition care that we considered based on this body of work is that, telehealth and nutrition really is feasible and acceptable, especially in the nutrition and weight management space. What we noticed amongst discussions with families is it did improve the accessibility to nutrition care and allowed for flexibility in that complex week structure. So you could have these quick check-ins, which didn't actually require a visit to the hospital. And sometimes with nutrition, gold standard weight management is about, frequent touch base. And so this telehealth format really made that possible. It also allowed for a very protected time to discuss nutrition and weight. So, in a neuromuscular clinic, it's busy. There's a lot of professionals wanting to see families, and there's a lot of information sharing during those days. So sometimes having these discussions about nutrition and weight can be really challenging in those busy clinics. So telehealth allows a protected time just to have these nutrition discussions. As Tash alluded to, it can be challenging measuring things such as weight and having appropriate access to equipment to do some of these monitoring was really challenging using the telehealth mode. And also, as we see adults kind of in clinic, we do think it's also important to have some face-to-face to see how nutrition is changing in the individual. So sometimes eyeballing someone from a nutrition perspective is really helpful. It helps us sense how things are going on. So, really our conclusions is that telehealth for nutrition is great, but perhaps, some hybrid models moving forward is the best space. So what's next for Snowy? We've been doing some work with Dr. Jared Wong in the UK, looking at whether Snowy might be actually an acceptable approach within the UK. And in Australia, we're continuing to explore options about how we can expand the research to look at efficacy more appropriately, and whether we can continue to provide this type of care as well, because it is outside of our typical neuromuscular clinics. So we need to think cleverly how we can fund these models of care as well. So thank you so much for your time today. And also thank you, of course, to all the families who've participated in this research. It helps us to understand the best ways to move forward. I hope you enjoy the rest of the CARE conference this year.
So as the nutrition presentation has ended, we thank Dr. Zoe Davidson and Natassja for making this presentation for us. And if you have any questions, please leave them in the Q&A session so we can forward them to them and kindly ask them to answer it. Now the floor is yours, Elizabeth. Thank you.
Yes, thank you. Thank you so much. The next speaker, and I see you're online, I saw you already online, is Professor Raja Padidela, and he was just mentioned by Dr. Jared Wong, who have been speaking about endocrinology in the past, and he recommended Professor Raja Padidela as a very good speaker for our conference, and we're very happy you're there. He is a consultant pediatric endocrinologist and metabolic bone disease specialist at Royal Manchester Children's Hospital in Manchester, United Kingdom. And he's well known in the field of bone health in the pediatric population. And he's also one of the authors on the paper about a randomized double-blind phase 3 trial with zoledronic, I can say it normally, acid versus placebo in pediatric corticoid-induced osteoporosis, which includes Duchenne patients. So we're very happy you're here. The floor is yours. Thank you for attending our conference. Thank you so much.
Thank you very much. Thank you for the opportunity. So I'm going to present on bone health and puberty in children with Duchenne muscular dystrophy. These are my disclosures. So in today's presentation, I'll be discussing pathophysiology of the effect of steroids on bone health. I'll discuss bone health in Duchenne muscular dystrophy, factors which contributes towards the bone health, how do we investigate them, and the management for improving bone health. I'll then discuss challenges and problems associated with puberty in Duchenne muscular dystrophy and how we manage these problems. So steroids has multiple effects on the bone. It reduces the bone formation by causing apoptosis of the bone formation cells called osteoblast. It also decreases the factors which increase osteoblastic function. It causes apoptosis of the chondrocytes of the growth plate, which then reduces growth. And in combination with delayed puberty and reduced muscle function, it reduces overall muscle function of the body, which then decreases the osteocytic bone formation and mechanosensing. It also causes apoptosis of osteocytes, the main cell which help in bone metabolism. It increases the bone resorption, breakdown of the bones by increasing the osteoclastic activity. So it's a perfect storm, and by this, steroids are causing osteoporosis of the bones. So what exactly happens in Duchenne muscular dystrophy? So steroids are standard of care in Duchenne muscular dystrophy. It improves ambulation, pulmonary function, and life expectancy. It reduces the risk of scoliosis and preserves cardiac function. Effects of steroids on bone in Duchenne muscular dystrophy is that it causes osteoporosis, which then causes long bone fractures and can cause fat embolism. It can cause vertebral fractures, which presents with back pain. It can reduce ambulation, especially if there is a lower limb fracture, and it reduces quality of life. So in DMD, The cause of osteoporosis is because of the long-term use of steroids. They do have reduced muscle function, which reduces bone formation and bone mass. They have delayed puberty, which can also reduce muscle function and reduce bone mass. And they can have concomitant vitamin D and or low dietary intake of dairy products rich in calcium, which can also affect bone health. So there are various studies which have shown that fracture prevalence is high in children with Duchenne muscular dystrophy. This study, which looked into 155 children with Duchenne muscular dystrophy, found that around half of them had fractures and quite a few of them had vertebral fractures. Vertebral fractures is not common in normal population unless there is significant trauma such as a road traffic accident. This is one of the studies which we undertook, compared children between two centers, Birmingham, where most of the patients were receiving intermittent steroids, and Manchester, where most of the patients were receiving daily steroids. As you can see from the graph on the left, those who were receiving daily steroids were ambulant for a longer duration of time compared to those who were receiving intermittent steroids. On the graph on the right, you will see that those who were receiving daily steroid had more prevalence of fractures compared to those who were receiving intermittent doses of steroids. So from our small study, we found that steroids did improve mobility if they were given daily, but there was increased prevalence of fractures in those who had more cumulative dose of steroid. One of the challenges we find with children with Duchenne muscular dystrophy who are ambulant are that if they have a lower limb fracture, then some of them unfortunately lose ambulation. And in this study, they looked into this, and what they found was that 40 patients with lower extremity fractures were evaluated. Out of them, 22 were ambulant, and out of these, 8 patients lost ambulation after fractures. So this is a high percentage of children who lost ambulation after lower limb fracture. How do we assess bone health in children with Duchenne muscular dystrophy? One of the most commonly used method is to use dual energy X-ray absorptiometry. It gives us an objective indicator of how strong the bones are. The radiation dose is minimal, and typically the scan is performed once a year. It gives a numerical value of how strong the bones are. In addition, it is very important to assess if there are vertebral fractures. Please remember that some of these vertebral fractures can be asymptomatic because steroids suppresses inflammation and reduces pain. So it is not uncommon for us to see children very late if pain is used as an indication for performing vertebral fracture assessment. So it is therefore our practice to assess vertebral fractures once a year. You can see that we can do vertebral fracture assessment using spine radiographs or DEXA scan. The problems with the spine radiographs is that if the bones are osteoporotic, as you can see from the middle panels, it is very difficult to visualize the morphology of the bones. And this is where the bone density scan using DEXA scan is very helpful, as most of the machines now have the capability to perform vertebral fracture assessment. Morphology of the vertebrae are much clearly visible. This allows us to identify early vertebral changes which suggest fracture, which then allows us to start treatment before pain manifests. So with regards to bone density scanning, we perform them once a year. We start from 5.5 years of age because our normative data is from 5.5 years of age. We also perform vertebral fracture assessment, mainly using bone density scan. But if bone density scan is not possible, then we perform spine X-rays once a year from 5 years of age. This is the recommendation which was published in Lancet of how we should monitor bone health in children with Duchenne's muscular dystrophy. To summarize, we review them once every 6 months. We assess if they have any back pain or if there was any history of long bone fractures. We perform bone density scan from 5.5 years of age. And as I mentioned previously, it is very important to assess for vertebral fractures in these scans. We make sure that their vitamin D levels are normal. In our center, we have found that giving 20,000 units every fortnight is very helpful. There is a reduction in the doses of medication they have to remember to take every day, and twice a month of high dose vitamin D seems to maintain their vitamin D within the normal range. We perform dietary calcium intake survey. We have a rapid assessment tool which allows us to assess their dietary calcium intake, and if the calcium intake is low, we encourage them to improve their intake of dairy products. And if there is any problem in taking dairy products, one can provide them with daily calcium supplementation. We assess mobility and physiotherapy support, and we assess puberty after starting from 9 years of age. So what is the diagnosis of osteoporosis in children, and what is the indication for managing osteoporosis in children? So there is this guidance from the International Society of Clinical Densitometry, and osteoporosis in children is defined as one or more vertebral fractures or clinically significant fracture history, 2 or more long bone fractures by the age of 10 years, or 3 or more long bone fractures by the age of 19 years. Low bone mineral density is taken into consideration, but low bone mineral density in itself does not confirm osteoporosis. Osteoporosis is only if there are vertebral fractures and there is history of long bone fractures without any history of trauma. Now, what about Duchenne's muscular dystrophy? Since prevalence of osteoporosis is high, since long bone fractures of the lower limb cause loss of ambulation, we are a bit more aggressive in starting treatment for osteoporosis in children with Duchenne's muscular dystrophy. If there is a single long bone fractures, if there is vertebral fractures, it is an indication to start bisphosphonate treatment. So looking at the guidance again, treat vitamin D and calcium deficiency. That in itself will not improve osteoporosis, but if children are deficient in calcium or vitamin D, it can worsen their osteoporosis. Make sure that they have normal renal function, as the treatment with bisphosphonate is only possible if renal function is maintained and normal. We perform bone density scan once a year to look into the bone mineral density as well as vertebral fracture assessment. So what's the treatment of osteoporosis in children? The treatment is intravenous bisphosphonate infusion. There is various schedules. The one which we use is IV zoledronic acid infusion, which is given at a dose of 0.05 milligrams per kg per dose every 6 months. It is important to make sure that children are regularly taking vitamin D supplementation, or else there can be significant hypocalcemia following infusion with zoledronic acid. So the calcium levels can drop down if vitamin D deficiency is present. Make sure that children have adequate intake of calcium in the form of dairy product. And we continue to perform yearly bone density scan along with vertebral fracture assessment. So what is the evidence of treating osteoporosis, steroid-induced osteoporosis with zoledronic acid infusion? This is one of the trials which was led by Professor Leanne Ward from Canada. I was part of this clinical trial where 36 children with vertebral fracture were recruited. All of them had osteoporosis secondary to long-term steroid intake. 13 of these children were with Duchenne's muscular dystrophy. As you can see that there was improvement in spinal BMD as well as height-adjusted spinal BMD-Z scores on those who received bisphosphonates compared to those who received placebo. This is one and only randomized controlled trial of steroid-induced osteoporosis. There has been some suggestion that we should consider prophylactic bisphosphonate, and the rationale for this is that fracture prevalence is high. There is loss of ambulation after long bone fractures. However, currently there is no evidence for bisphosphonate treatment as a prophylaxis, and our practice is to introduce treatment at the earliest possible vertebral fracture changes. And therefore, it is very important to have yearly vertebral fracture assessment performed to pick up vertebral changes at the earliest possibility and introduce treatment before vertebral fractures worsen. It is likely that it may be suggested as a standard of care in the coming consensus statement, but I'm not sure about that. This discussion is still ongoing. Now, it is very important that steroid stress dosing is given when children are receiving bisphosphonate infusion. Because of long-term steroid intake, children with Duchenne's muscular dystrophy have adrenal insufficiency. If they are taking prednisolone, they simply need to split the dose and give it twice a day. If they're taking deflazacort, then they will have to introduce some oral hydrocortisone medication, as deflazacort is short-acting and we need a 24-hour good coverage of steroid when they're receiving bisphosphonate infusion. If they are unable to tolerate oral steroids, they may require intramuscular or intravenous hydrocortisone as per the schedule which I have provided here. It is extremely important that stress dosing is discussed with the families in every clinic appointment. This is my typical clinic letter for a patient with Duchenne's muscular dystrophy. Besides discussing their bone health and puberty, I always make sure that adrenal insufficiency management is clear and up to date, and parents have good understanding of this. This can be life-saving in serious illnesses. Now, how do we treat and maintain? We perform yearly bone density scans when children are receiving bisphosphonate. We continue to perform yearly fracture assessment. We reduce the dose of bisphosphonate if bone mineral density is high and vertebral fracture assessment is showing that vertebral morphology has improved. We do stop bisphosphonate if steroids have been stopped and if there is normal bone mineral density and vertebral fracture assessment shows healing of vertebral fractures. If puberty is complete and if bone mineral density and vertebral fracture assessment are normal, then we can discontinue bisphosphonate treatment. Moving on to delayed puberty. Onset of puberty is delayed if it occurs after 14 years of age. The only way to assess puberty is to check for testicular volume. Onset of puberty is if the testicular volume is more than 4 milliliters. Please make sure that testicular volume is assessed. Other features such as pubic hair and changes in the voice occurs after puberty has set in. And therefore, the earliest changes of onset of puberty is not pubic hair or axillary hairs, but it is the change in the testicular size. And why puberty is important? It is important for development of secondary sexual characteristic. It causes growth acceleration. It increases muscle and bone mass. So most children do have osteoporosis, and making them go through puberty can help in preventing the factors which contributes towards osteoporosis. It also improves mood, confidence, and self-image. Most children treated with steroids have delayed puberty, and therefore it is important to assess puberty in all children. And this is again the Lancet consensus guidance, which suggests that one should start assessing puberty from 9 years of age. And delayed puberty is when the testicular volume is less than 4 centimeters cube at 14 years of age. Children should be referred to endocrinologist for assessment and management of puberty. Assessment could be done by laboratory analysis, but the most important assessment is clinical examination to check the size of the testes. Now, how do we kickstart puberty in children with delayed puberty? Testosterone replacement therapy is what is advised to kickstart puberty. One could start thinking of kickstarting puberty from 12 years of age, given that most children with Duchenne muscular dystrophy have delayed puberty. And the reason I say 12 years is because average age of onset of puberty is 12 years. It can be done by intramuscular injections or by topical testosterone gel. We prefer intramuscular injections. It can be given as short courses where we start with 50 to 75 milligrams every 4 weeks for 4 to 6 months and increase based on the testicular volume. This is continued till testicular volume reaches 6 to 8 milliliters, following which we discontinue testosterone treatment and allow the boys to go through puberty on their own. The other schedule is to take them all through the puberty and complete pubertal development. But there is a balance which has to be maintained between stimulation and of puberty versus suppression. A short course can stimulate puberty, but very long course or high doses can potentially suppress pubertal development. To summarize, bone health assessment by DEXA scan and assessment of backbones by vertebral fracture assessment. DEXA scan is important to get the numerical values, but more important is to look for vertebral fracture and history of long bone fractures. Treatment with bisphosphonate is commenced not based on the low bone mineral density results, but based on long bone fractures and or backbone fractures. High-dose steroids can suppress adrenal glands, and therefore it is important to advise on stress dosing with intercurrent illnesses and also with bisphosphonate infusion. Pubertal delay is common. Most children will require kickstarting puberty, and one should consider to introduce this from 12 years of age, but definitely should be introduced at 14 years if the testicular volume is small. Thank you very much, and I'm happy to take any questions you may have. Thank you.
Thank you, Professor Padidela. We do have one question. Someone from the audience is asking, what will switching from prednisolone to Agamree do? If you have experience with that, how it will affect bone density, and if we can expect that it will improve the result?
No, I think we still have to continue to monitor bone density scans and vertebral fracture assessment as we do. From my recollection of the literature, the vertebral fracture assessment and adrenal insufficiency still remains a problem.
Thank you. There is another question about treating patients with denosumab, if you have treated any patients with that, and if you can share your experience in the Q&A session.
Yeah, it's a very important question. It is logical that it's a low turnover disease, so denosumab could be used. I have not used it. My colleagues have used it. Professor Leanne Ward has tried to do a clinical trial using denosumab, but when I last spoke to her, she had a child with severe hypercalcemia, and therefore the whole research trial was abandoned. So one of the complications of denosumab in children is rebound hypercalcemia, and it also happened in a child with Duchenne muscular dystrophy. So it should not be given in children with Duchenne muscular dystrophy to treat osteoporosis.
Thank you. And last question to close with. Any recommendation about bone density and assisted orthostatism, if assisted orthostatism can affect bone density?
Sorry, I don't understand the question.
So I
Assisted.
think it's about sitting upright and trying to practice sitting if it can affect bone density.
Yeah, I don't think it will significantly change bone density. The most important factor which changes bone mineral density is reducing the steroid dose and improving mobility, and both of them are challenging to perform in children with Duchenne muscular dystrophy. But any physiotherapy, any factors like hydrotherapy, which can be implemented, can contribute towards improving bone mineral density, but on itself, it cannot improve bone mineral density to such an extent that we wouldn't require any further treatment.
Thank you.
Thank you.
Thank you so much, you, but also all the other speakers. I see some of them are still online and watching the whole program. And then tomorrow, and I think Suzanne will now share a slide with us. The program for tomorrow is as follows. And we hope to see you all tomorrow again, because again, we have a lot of very good speakers. And I wish you a good evening, afternoon, night, whatever it is in your place. Thank you so much, the participants, the presenters, everybody, and see you tomorrow.